All right, thanks everyone. We're going to move along here. My name is Wes Clayton. I am a sport med and family medicine doctor in Collingwood. Everyone know where Collingwood is? Yeah, nods. I have no disclosures here, but that's where it is. That's my little town. That's my house. Come visit if you're in the neighborhood. That's where she is. So some people think that that's Northern Ontario. It took me an hour and 45 yesterday in rush hour, so it's not bad. That's Northern Ontario. So just let's just readjust our perspective a bit, which is what we're doing today. I'm going to focus mostly on corticosteroid injections, hyaluronic acid, and PRP. And I finished my sport and exercise medicine fellowship at Western 10 years ago. It's our anniversary, Dave. Congratulations, we did it. Yeah, so 10 years. So, and I've obviously gone to conferences in that time frame and done a lot of reading myself. And I just wanted to kind of take this opportunity to kind of refresh for myself too about what exists out there, what's changed. I mean, when you get into practice for more than a couple of years, things have completely changed a lot of times. So I think a lot of times it's nice to kind of serve these doing talks and going to conferences like this. It's nice to take an opportunity to kind of refresh. And so one of the things that I wanted to do was just kind of go back, not really just to basics, but just get a sense of reflecting on why we do things. And a lot of things we do in medicine, not just in injections, but in sports medicine and in family medicine, it's things are guided by evidence. We apply the best available evidence when we make decisions and discuss treatment plans and diagnoses with our patients. But and sometimes we have evidence, sometimes we don't, and sometimes we have to discuss that with patients. That well, this is the evidence for this treatment, and I think that's appropriate as a next step. And sometimes we go beyond that and say, well, we have limited evidence for this, but given the circumstances, given our goals, given our discussions, maybe it's worth trying. So this is meant to discuss the evidence that I could find in terms of these sorts of things. Doesn't mean that if we find that maybe hyaluronic acid isn't all it's cracked up to be sometimes when we describe things, doesn't mean we shouldn't be doing it. And certainly with all the injections that I'm going to talk about, I've done myself, and I still do. So I think it's just thinking about reflecting on your own practice, how you discuss this sort of stuff with your patients in terms of our recommendations when they're coming to you for advice, for a diagnosis. So we've got residents in the audience. Can I show of hands if you're a resident? Okay, and then and in practice, I guess the rest. Who is doing injections on a regular basis? Great. Most. Who corticosteroid injections on a weekly basis at least? Hyaluronic acid, keep your hands up. And PRP. Couple, 3, 4. Okay. So I'm going to focus primarily on those three things, like I said. There's a lot of other things. Maybe if I get invited back next year, I can talk about the other ones, or at least look at why we maybe should or shouldn't be doing the other ones. So regardless of where we are on the spectrum of confidence with injections, you might be there, you might be there, you might be there, you might be there, and think you're really good, and then you're actually there looking stuff up after patients leave or while they're in the room. I like this picture here. Have you ever given someone a left-handed handshake and held their hand out of comfort? Like, that's ridiculous. I'm gonna start trying to see if that actually helps comfort patients, but I like that one better. Because what really this is informing, hopefully, and hopefully it will for all of you, and it certainly did for me looking at this talk, was how we can better explain things to patients and what we can offer them, and explain the benefits and maybe limitations of what we are offering to manage expectations. And so I think that's what I hope you can get out of this talk. I'm going to talk about what I do, and that's sort of how I approach this sort of stuff. Just a quick reminder on grading of OA on radiographs. A lot of the evidence that I could find for these sorts of things fell into the mild to moderate severity range for OA. So just kind of keep that in mind when we talk about things, because I think a lot of times I might be seeing that grade 3, 4 patient and then saying, well, they don't want surgery, so what do we have to offer them? And what does the evidence say for that? And really, I don't know. I couldn't find much on that. So really, we're thinking about that mild to moderate OA patient. So keep that in mind. Keep that in context when we talk about a lot of this stuff. Some people come in saying, I want an injection, let's go. And I say, well, hang on. Let's talk about this first. What have you tried? And sometimes they are apprehensive. My friend said it hurts a lot. Or I had a cortisone injection for my shoulder 10 years ago and it didn't work, so I don't want it today. And so I'm sure a lot of you have these conversations every day like I do. And I think having a more grounded approach, as well as reflecting on how you approach those conversations and the words you use and the language we use, really can be helpful for patients to clarify things, whether they end up having that injection or not. So we're going to put this in context. I'm not going to talk really much about non-injection therapies. We're focused on injections. But again, keeping that in mind of where injections fall in the spectrum of treatment, especially when we talk about OA, which we're going to mostly talk about. Okay. So I just quickly, briefly, guidelines. Everyone loves guidelines, right? Resident, I love guidelines as a resident. And ultimately, there's, for knee OA in particular, we'll talk about OA guidelines. There's a few that I want to highlight. If anyone wants these slides, I'll send them to Neil. I tried earlier and it wouldn't work, but I'll send them out. I basically put all of the papers kind of on the slides. So if you're interested, you want to read a bit more, you can go into that sort of stuff when you have the slides. But for knee OA, this is the OARSI guidelines. Intra-articular corticosteroids, IACS, we'll see that a few times, conditionally recommended for acute and short-term, that's up to 6 weeks, pain in knee OA. And then IA hyaluronic acid, IAHA, conditionally recommended for longer-term treatment beyond 12 weeks, okay? And maybe it's safer, but who knows. Hip OA, no treatment strongly recommended, okay? So we'll kind of come back to that, and lower grade evidence for our intra-articular corticosteroids. So actually was not recommended for hip OA. And then they recommended against PRP. So again, just park that aside here. This one is another guideline talking about intra-articular corticosteroids, maybe short-term relief again, great. Didn't recommend HA, and PRP might, who knows, limited strength recommendation. This is a great, I think the 2019 American College of Rheumatology Foundation guideline. I like these, I like pictures. This is a nice picture. It's got little different shades of green, all the different stuff. Puts this in context in terms of where we're talking in terms of injections. They basically said that there's no hierarchy on that, so it's not meant to be, top to bottom. Hand, knee, and hip OA at the top there, just kind of looking at what the evidence states for all of them, or at least what they agreed upon. Corticosteroids conditionally recommended for hands, but there wasn't much evidence for it. Knee, hip, and/or hand OA steroids conditionally recommended over other injections, including HA. But few head-to-head comparisons, really poor quality evidence, etc. And corticosteroids had more evidence there. This is the not recommended section, okay? And you can see IAHA comes in at hip, and maybe there was some agreement in terms of not recommending that for knee and hand, interestingly enough. And ultimately, there's a high risk of bias. That's why they kind of throw it on there in terms of HA. The evidence of benefit in studies was really restricted to those studies at high risk of bias. So that kind of informed this too. And in studies where there was a lower risk of bias, that effect size ended up being similar to intra-articular saline. And we'll kind of talk a bit about that in a couple of slides here too. So the conditional recommendation against the use of IAHA or hyaluronic acid is in the context, should be, what is it? So it's consistent with the use of IAHA injections in the context of shared decision-making when other alternatives have been exhausted or failed to provide satisfactory benefits. So they basically put that little thing in the end saying, hey, you still use them, don't worry, but we got to, again, put it in context. So with respect to the hip, you can see that's that's really red there. That's bad. Red is bad. Pink is not as bad. So there was higher quality evidence to say that hip injections with IAHA was not helpful, not effective. So where do injections fit in? So we're going to focus mostly on some studies that looked at systematic reviews, network meta-analyses. This one looked at some oral and intra-articular placebo, which is kind of important here, and a bunch of other oral things in terms of NSAIDs. The steroids and the HA didn't include PRP in this one. They calculated sort of standard mean differences for pain, function. They kind of create, most of these things, different pain and function scales are used. So they kind of create everything, put everything together, try to find some standardization, and then they kind of throw it into the Google machine and see what happens, right? So they were evaluating this at 3 months, and that actually was really from 2 to 6 months. So just again, keep that in mind when we're talking about this study. And what I liked about this paper was they talked about clinical significance. I found very few, even systematic reviews, meta-analyses that looked at clinical significance. Talk about statistical significance, great, but is this going to help my patient? Is it going to help our patients? And so a lot of studies look at sort of anywhere from 10 to 15% change in a scale as clinically significant or potentially clinically significant. They determined that a 20% plus point change on a 0 to 100 scale would be clinically significant when they kind of converted all of these scales. So basically, this is a quick little graph on that blue line going top to bottom at 20 is that clinical significance scale. So in this meta-analysis and a network meta-analysis and systematic review, everything was better than oral placebo, okay? So statistically, but when you look at that line, there's one that crosses it, which is intra-articular placebo and acetaminophen. So everything else was clinically significant. So all of those treatments they found were actually potentially clinically significant, but they were all, even including intra-articular placebo, was better than oral placebo. And so acetaminophen, basically, when you look at this, that doesn't seem to work very well clinically versus but it was statistically significant. And then all intra-articular treatments, which is what we're focused on here down at the bottom, steroids and hyaluronic acid, seem to be, again, at that 2 to 6 month window, clinically significant. Okay. And then they looked at comparisons, and they said the steroids were better than oral placebo, Tylenol or acetaminophen, and intra-articular placebo. And then HA better than oral placebo, like I said before, acetaminophen, intra-articular placebo. But they didn't really talk about clinical significance when they compared those to all the other treatments. So again, this is against oral placebo, and then when they compared them all, they didn't really talk about clinical significance. So that was for pain. So we're focused on that. So in that time frame, based on this, I'm thinking, okay, well, maybe there's some benefit to steroids, maybe some benefit to hyaluronic acid. But intra-articular placebo did really well, really well. There was potentially some clinical significance there, right? So I think just keep that in mind. Again, we're talking about knee OA here. And then they looked at function and stiffness as well based on different scales. And all their other meta-analyses have found like non-clinically important benefits of HA versus intra-articular HA versus intra-articular placebo. And so really what came out of all this was, yes, NSAIDs were fine and all that stuff, but focusing on the injections, there seems to be a really strong intra-articular placebo effect, okay? And so has anyone tried injecting saline into their patients' joints to see if they got better? Andy, okay.
A lot of poor people that
Yeah.
and a lot of them can't take cortisone. Yeah, I've tried it a few times. It's been better than 50.
Yeah, that's one of the biggest things that I took away from preparing for this is maybe I should be offering that or just discussing that with patients. So just a quick sidebar, HA buffet. So we're talking about, I mean, probably some of you are familiar with this. I remember hearing about this years ago. Is there evidence that there's one product that's better than others in terms of molecular weight? And there's one example of a study there that looked at high molecular weight hyaluronic acid, so different. The definition of what that is, some said over 3,000 kilodalton, some said over 6,000 versus lower, and they found a statistical, not clinical significance with respect to improvements in pain. The ones in the middle, they didn't see any improvement statistically. So there seems to be, based on that, maybe some statistical significance, whether that's clinical, not sure. And in case you're wondering, well, I don't remember how many kilodaltons my favorite HA is. That's 6,000, and that's bajillions. I don't know how many, but they don't really say, but bajillions. I mean, in our office, we have monovisc, which is anywhere from, I think, 1,900 to 3,000. Anyway, the point being, like, I don't know, maybe thinking about it. If someone's gonna write if I'm gonna write a prescription for someone, I usually write Durolane, but that's just me. But does HA work? So now we go back to, we talked about 3 months. Now we're talking about 6 weeks. So super hyper, acute symptoms with respect to knee OA. And this compared, PRP was in this meta-analysis and systematic review, as well as a lot of those other comparators as well. Sidebar, naproxen was the big winner on this one, which is interesting, and something I quite often do. But this one was much more restricted than the last one in terms of what they included and what they excluded in terms of their criteria. So this had only about 12 studies included versus 52 in the previous one. Just kind of, again, thinking about that. So all active intra-articular treatments were statistically significant over oral placebo. Again, but not for function, interestingly enough. Only the steroids showed statistical significance over the intra-articular placebo. Again, we're talking about, that 6 weeks. Kind of similar to what I would think and what I remember is like, okay, cortisones work in the short term. Intraarticular hyaluronic acid, no better than any other treatment in that, again, 6-week time frame. So this is a quick what I do. I mean, this is, I put the slide in because a lot of the stuff is not, this is just what I learned, what I was taught, what I figured worked, what I asked my colleagues about, what they were doing. This is not meant to be a guideline for you at all. The 3-month rule, it's like the 5-second rule. That idea of we can't do injections, 3 months is the absolute, if you have an injection at 2 months, 28 days, your knee's gonna fall off. Like that's not, like where did that come from? That's from studies from the 60s and 70s, right? Of like, if we did these more frequently, there's likely gonna be a deleterious effect on the joint in some way. But I still use that 3-month rule. Who uses that 3-month rule, right? Just something to think about. Neil already talked about this. I put a few up on here, and there's a couple of papers there, references that you can kind of look into as well. But again, like he was saying, we really don't have a lot of good evidence or a lot of good data on this at all. And I similarly to infection rates that Neil was talking about too, 1 in maybe 10,000 or less. Arthroplasty infections, our orthopedic surgical colleagues talk about this quite often. We don't want to do an intraarticular corticosteroid injection and then go in and have a surgery because your infection risk go up. I've heard that range from 2 months to 6 months. So our orthopedic surgeons in town suggest 3 months, but that's interesting. And then this whole idea of OA progression, and I thought that paper was quite good there, talking about showing potentially, actually this paper did show a reduction in the mean cartilage thickness after people received corticosteroid injections in that interval for over 2 years. I don't do many corticosteroid injections every 3 months for 2 years in patients, generally speaking, if that's what they need. We're talking about other things, maybe to help them provide a little bit longer benefit, but that's interesting. The point about that, I think I drew from that is there was secondary outcomes that they didn't find any benefit for. And we don't know, like, if you lose 0.21 millimeters of cartilage, what does that mean? Like, does that change their pain? Does that change their function? Does that increase the rate of their progression to needing a joint replacement? None of that's been studied. None of that's been determined. So yes, if people ask about safety, I think that's going to be a bit of something that I can kind of throw in the back of my mind in terms of in my back pocket of describing that to patients. And certainly there's evidence too, and studies that looked at a deleterious effect of local anesthetic on chondrocytes. So, and that's like in vitro studies. So that's something that, again, like what are we, maybe not. The corticosteroids have been around for a long time. We have some data to suggest that it might, again, over 2 years, Q3-month injections might reduce cartilage thickness by fractions of a millimeter, but what does that mean? And we don't know that means anything. So keep that in context, is what I'd say. This is a really good, I thought this was a really great one-pager in the Canadian Family Physician Journal not too long ago, comparing which steroids. And who uses mostly Depomedrol here? Who uses mostly Kenalog here? And who uses anything else? Yeah, so it's one of the two ones, right, typically. They talked about a couple studies, and I think there were 3 RCTs about different steroids, different doses. So this one, no difference. Similar functional outcomes at 4 and 24 weeks using Kenalog versus Depomedrol 40. This one looked at Kenalog 20 versus Depomedrol 40 and found no difference at 8 weeks, which I thought was interesting too. I've always thought, like I showed you in that previous slide, big joints, throw 80 in there. After this, maybe 40 is good enough. I don't know, right? Or maybe, heck, maybe 20 is good enough. Again, this was for knee OA in particular. And again, mild to moderate OA in both of those. And then this one compared Celestone, Depo, Kenalog, and saline, which I thought was really cool. And 120 patients, mild OA, significant pain, at least 5 out of 10 on a visual analog scale. Pain and functional improvements, all 3 steroids better at 12 weeks versus the placebo, but no different from each other. So I thought that was great. That was a one-pager that talked about all that. That is clinically relevant, I thought, for me and probably for most of you, and kind of answer some questions I've had for a long time about what we are doing and what I'm doing in practice. So here we talked about 6 weeks. We talked about 2 to 6 months or 3 months. Now, what about 6 months? This is, again, another network meta-analysis, systematic review of HA, cortisone, PRP, plasma-rich and growth factors, and placebo. And I think in this study, I think placebo, I couldn't find it. I think that was oral placebo. I think I couldn't see them. I couldn't see anywhere where it said anything different. So minimum of 6 months. And in this one, we saw that PRP had the largest effect versus placebo. Again, I think oral placebo on pain and function. All intra-articular treatments except steroids were statistically significant versus placebo. Again, this is statistical significance, and that's the PRP there. So again, statistical significance, a lot of heterogeneity. Most of the comparisons had that. So again, huge or lots of grains of salt in this, okay? But kind of goes with what we think. Like steroids work in the short term and then don't really work longer term than that. That's why we have to repeat them so frequently potentially. But maybe there's something to PRP in the OA that we are seeing or would see a bit longer benefit or sustained benefit. This was a great quick little diagram I'm going to show you too. So in this study, they actually looked at clinical significance as well in terms of all these comparisons. Basically down the left-hand column there for pain and function, looking at the one on that column on the left there, so PRP versus all the other ones. And if it's all the bold ones are statistically significant. So anything over 1 was considered clinically significant. So in this case, all intra-articular treatments except steroids were statistically significant versus placebo. And I'll show you here. These are the ones that were likely clinically significant. So that's PRP over steroids, again at 6 months, PRP over placebo, and this platelet-rich and growth factors over placebo. Between 0.5 and 1 were likely of clinical significance. So that's PRP over steroids and placebo for pain, as well as over HA for function. And then PRP was, again, 0.49 there against HA in the top, not quite, potentially clinically significant. And then the platelet-rich and growth factors, we're talking about. So I thought that was a really good one. I kind of like this one. Of all the kind of stuff I looked at for PRP, I like this. This is the graph that I found quite interesting. Okay, so here's a trial looking at only 8 trials, a few hundred patients. Most, again, that sort of mild to moderate OA. A single PRP injection was done in 6 of those studies and multiple in 3. What is again, looking at pain, function at 6 months, looking at that versus steroids. Okay, so now we're looking at, again, is PRP better than steroids at 6 months? Everything on the left of those force plot is PRP favoring that. Everything on the right is steroids. So we're seeing that this, again, favoring PRP. And then they broke it down based on 1, 3, 6, 9, and 12 months, which I thought was kind of interesting too. Most of the data and the sort of strongest, evidence would hit at that 6-month mark. And you can see that 1 month mark, if you look at that top diamond, really no difference. And then you start to see that difference come out. And then at 12 months, not much difference, but it's only based on 2 studies. So looking in that 3 to 6 month window, I think that that's where we're potentially seeing PRP better than corticosteroids I'm talking about. Again, this is statistical significance. Again, not clinical significance, which we talked about before. So then they stratified this data based on disease severity. And then between there, the Kellgren-Lawrence grade 2, 3 showed that's a mild to moderate OA. Kind of weird to think 2 is mild, but that's how the scale goes. That's where most of the benefit is. So again, that person who has severe end-stage OA, am I going to sit in my office and say, I think you should get PRP, that's going to likely help you? I'm not going to say that, right? We're going to talk about it. If they want to give it a try, we're going to talk about the evidence and discuss what that means for them. But that mild to moderate range, which I think most of us are dealing with in terms of these types of injection therapies, that's where that sits. So I'm not going to go too much into leukocyte-rich and leukocyte-poor PRP, but they did tease them out or stratify them based on that, and they both showed a difference. Again, they didn't compare the two, so don't get too caught up in how big those diamonds or how where those diamonds sit on that scale. But they both were better than steroid. Okay, so there's some suggestion we'll talk about in a second about leukocyte-poor being better, but again, based on this, they both seem to do better. And then single versus multiple PRP injections, again, they both seem to do better. Again, they didn't compare them, so just because that single injection maybe touches that line, they seem to both do better. But again, I can't compare them. So this looked at PRP versus HA at 11 months, okay? So a mean of 11 months. And saying, okay, well, now we've talked about 6 months. What about at that year or close to that year mark? Looking at pain and function as well again. PRP was better on the WOMAC versus HA at a group less than 12 months and greater than 12 months. PRP was better in terms of IKDC scores than the IHA at the 12+ month follow-up, but there's no difference between PRP and HA in pain scores in those times. So function, pain, again, mixed, a lot of heterogeneity. This was based off of 7 studies. This was based off of platelet concentrations. Again, a lot of differences in terms of PRP preparation. They only reported in 7 studies a lot of that data. Systems they used were most of the time unreported. 8 used leukocyte rich and 7 studies used leukocyte poor PRP. It's about 15 studies. 3 didn't report their molecular weight they used, low molecular weight of HA in 3, and high molecular weight in 13. So again, like just throw it into the bag and pick one out, and that's sort of what they were looking at. But again, that's what you get when you're combining a ton of different studies with a ton of different variability, right? So I think we have a ton of loose threads still on PRP for knee OA. What do we use? There's a paper talking about maybe leukocyte poor PRP being better than leukocyte rich. But again, that has gone back and forth a little bit. How do we prepare this? How many injections do we do? And going back to that study, I think we can just I'm going to reiterate that only about 12% of them reported on their protocol the variables necessary to then repeat that study. So just think about sort of, again, in context. So I think there's some things that I think this is helpful in terms of teasing out, but we still have a ton of loose threads as it pertains to what and how we use our PRP in these patients. So what I do, I mean, like I talked about already, maybe a bit of steroid at the start if we're interested in doing that, but certainly looking at HA, I still use it. But and a lot of insurance companies cover HA now, right? So I think if we're talking about cost of patient and patient values and preferences, I think there's still something to try there. I think safety data for whatever we have on that would not preclude that possibility. But I think PRP, for me, this tells me that if we're going to talk about what's the best treatment in terms of an injection in these mild to moderate knee OA patients from 6 to 12 months, that's what I'm talking about over the HA. So what about my hip? This is a great paper looking at, again, clinical significance. So the MCID there talks about the minimal clinical important difference in terms of improvements in pain and now functional, I'll show you in a second, for hip OA, again, mild to moderate hip OA. And as you can see here, this is a network meta-analysis again, and all interventions, including the placebo, in terms of that, the placebo being the normal saline injection, the blue bars there, and then the steroids being orange, the HA in gray. They combined HA and PRP, which wasn't significant, but PRP being red. All of those were statistically significant versus control, except for that combined one. And they all include the minimally clinically important difference for pain and for function, actually, which is interesting. And this is that, but there was no significant improvements when compared to saline at 2 to 4 months and 6 months for pain and function. So they all seem to do better than oral placebo. But again, there's something about, seems to be, sticking a needle and putting saline into a joint that seems to help. So if I'm going to sit to someone with hip OA and say, well, we're not in this surgery scenario, we're failing all our conservative treatment options otherwise, what are our next steps? I don't know. I might start using or asking for intraarticular saline to be done. I don't know. Were the hips, Andy, that you did? Okay. Maybe I'll start sending you some saline hip injections. But I thought that one was really interesting. And why is it different than knee OA? Some suggestion about joint morphology and different things like that. So unsure why, but again, this is suggesting that there might be a difference in how these injections help OA in different places. So what about my shoulder? So I'm going to talk a bit about PRP here too. I mean, I'm not going to go into everything, but I think just some key points to think about in terms of PRP for other things. So we talked about knee OA, we talked about hip OA, but now what about subacromial impingement, as well as rotator cuff tendinopathies and partial tears. So this looked at PRP not improving functional outcomes or pain scores versus saline, dry needling, or steroids in terms of, and this was based off of 40, 42, and 40 patients. So small studies, okay? PRP versus saline at 1 month, no difference. PRP versus exercise at 6 months, no difference in visual analog scale for pain, but exercise was better at 1 to 3 months and at 6 months for a couple of functional scales and range of motion on NIRS test. And at 12 months, PRP versus exercise, range of motion was better in the exercise group. Both were statistically significant improvements in visual analog scale for pain as well as DASH scores, but there's no difference between them. Okay, so we're talking about PRP and exercise, which I think a lot of time we're talking about for rotator cuff tendinopathies, impingement, partial thickness tears, etc. That's the sort of stuff. That's what I'm talking about. Can we augment a response to exercise in these patients or not? I don't know if we can. I'm not sure. I couldn't find much on in terms of high quality studies on full thickness tears. Was restricted to studies looking at tendinopathy, impingement, and partial thickness tears as identified on imaging, ultrasound or MRI. I think most of them were MRI actually. They also looked at steroids as well at 6 months and didn't see a difference between PRP and steroids, and that's subacromial steroid injection. So the American Academy of Orthopedic Surgeons ortho guidelines, this was their quote: moderate evidence supports the use of a single injection of steroid with local anesthetic for short-term improvements in both pain and function for patients with shoulder pain. That was what their conclusion was there. All right. So this looked at PRP versus exercise specifically for impingement, and there's the evidence there. Both were better, but no difference between them. And then this was one looking at PRP versus placebo injection for chronic tendinopathy, and that was defined as I think over 3 months. No difference, similar results. So that was the ortho guidelines kind of conclusion based off of those studies. And then full thickness, there wasn't much evidence. That was their conclusion there. So what about my heel spur, right? So these are questions actually I've had in my office in the last 6 months. So rotator cuff tears, that one came from my mom, who asked me about her rotator cuff tendinopathy and whether she should get PRP or not. This one came from a patient that walked in my office demanding I give him a cortisone shot for his chronic plantar fasciitis. So this one looked at PRP, not showing an advantage over steroids within the first month, but seemed to get better thereafter. Okay, this was a systematic review and meta-analysis. Okay, 15 studies, 9 were at high risk of bias, only 1 was of high quality, and we don't know how they prepared. Well, we do know to some degree how some of them prepared their PRP, but there was no standardization. So again, take that with a grain of salt. And that was their last line of the paper. I love that. It's like I went on for 15 pages, and then that's the last line. What about my Achilles? I also had this question recently as well. So this is Achilles tendinopathy, mid Achilles tendinopathy for more than 3 months. Single leukocyte-rich PRP versus a sham dry subcutaneous injection. So they didn't actually push any injected in there, thinking that there might be some benefit to dry needling or to actually pushing fluid in and around that tendon sheath. So they just stuck a needle in, kind of mimicked or mimed pushing something, I guess, or looked away like Neil suggests. No difference. Okay, at 3 months or greater than 3 months. Or that was greater at 6 months with symptoms greater than 3 months. What about my golfers? I've had a couple guys, not golfing, but a couple cases lately with chronic lateral epicondylalgia, epicondylitis, home extensor tendinopathy, whatever you want to call it. I got a chef I'm thinking about that's had a lot of issues with this for a long period of time. And we've tried different injections, we've tried different things. So for him, I'm thinking, well, maybe I should be talking about PRP. I don't know if it's any better. So we're going to try that with him next, but he's failed a lot of injections as well so far. Again, this is 5 RCTs, that's it, on under 300 patients. So not a lot there, right? And this is both pain and function. But again, as what I said this entire talk, high heterogeneity across trials, number of injections, whether you use image guidance or not, et cetera. So my takeaways. I think there's only a couple things that I looked through the literature here talking about clinical significance, which is actually what matters to us, what matters to our patients. So more need to highlight that. And I think when we're reviewing this, when I'm reviewing this sort of stuff in the future, And when you're reading these papers, and when you're going to talks, frankly, thinking about whether what's being presented as statistically significant actually is clinically relevant to your patient and will maybe provide your patient with clinical benefit. And again, going back to mild to moderate OA, not severe. Again, I'm seeing patients who are maybe a bit older, maybe have other contraindications to treatments, are not maybe potentially suitable for surgery, and we're talking about injection therapies for their knee OA or their hip OA. Let's kind of think about where that evidence lies in terms of all of the stuff I presented, which is really just a mild to moderate OA. Doesn't mean we don't try things, doesn't mean we don't talk to patients about what their needs, desires are or benefit, but again, thinking about context when we're describing, presenting, and talking about these treatments as options. So placebo is a powerful drug, especially intra-articular placebo. Steroids, as I think most of us are familiar with and consistent with what I've been thinking and doing for quite a while, 6 weeks to maybe 3 months, maybe even kind of less than that potentially, but PRP seems to be better as we get into that 6 to 12 month mark compared to hyaluronic acid. I don't know what's going to work for hip OAs. I'm going to start sending Andy a bunch of saline injections for hip OA and see what happens, because I think that's the best we got. Maybe PRP for rotator cuff and mid-portion Achilles tendinopathy, not great. Maybe for plantar fasciitis, yay. And maybe for, I always thought, I was thinking that things get in your brain and that's like an automatic thought, and you go like, oh, lateral penalized PRP is great. So I was thinking this is great. I don't know. Maybe I've turned on that one since I've done this talk. I don't know where you guys are at with that. But again, I think that's my big takeaways here. So I need to think about dose of what I do with corticosteroids. I got to think about whether steroids are really meant to last 3 months, or maybe I'm just thinking that that's the 5-second rule, and maybe it's 6 weeks, maybe it's 2 months, or what to expect with benefit. Thinking about whether patients have coverage, can they afford the PRP? If they can, let's talk about PRP maybe potentially for me. But if not, we can certainly still try the HA for knee OA. And I don't know what I'm going to do with hips. If you have any great ideas, let me know. So next time your patient said they've done their own research and stuck the PRP and cortisones and hyaluronic acid for my knee arthritis and come up with an answer and tell you what they've done, you have hopefully a little bit more ammunition to talk about benefits, risks, and what the patient preferences are when you're deciding what injections are going to be right for that patient next. So that's it, guys. Any questions?
Question. For the PRP for like lateral myelitis or plantar fasciitis, how does a lot of heterogeneity in terms of the technique of PRP injection, not just what they're processing it? I find some studies that they just feel the maximal tendon versus traditionally what I've been taught is you're actually injecting things in the fascia or tendon or something like that, which I find is very hard to compare to a placebo because you can't really take that pain. I'm curious if you saw anything that specifies what technique they were doing.
No, with these larger like meta-analyses, like they were so much different. I just at the Achilles one was interesting because they just didn't inject because they thought there would be a benefit from pushing something in and around that tendon. But no, with plantar fasciitis, I didn't tease that out. No, but
when you do PRP, are you injecting just like peritoneus, or are you actually going?
Good question, because I don't inject PRP. So, but again, for people that are doing it, what do you do?
Yeah, I think it really depends on what the problems and what the pathology is, and what your goal is. Like, if it's a partial thickness tear, say the common extensor tendon, I find PRP is amazing. Like, despite what that study said, a lot of the other studies that we said were very positive for it, and they were great. If it's a cortisone injection, the person doesn't want to do the PRP, he understands the risk, and then I'm just baiting peritendinous, not penetrating the tendon, just on top, and they love it. But then 3 months later, they're golfing nonstop and comes back, yada yada. So I think it depends on what the pathology is and what your goals are. In the partial thickness tears, I tend to be right inside the tendon.
Yeah, that makes sense.
It's a tendinosis. It looks there's hypoechoic areas, but nothing that you can really get in. The trouble is, oftentimes you'll have this, say, 2.5, 3 cc's worth of, say, glucoside-rich PRP preparation, and you go to push it into this tendinosis tendon. The resistance is it's really tough. So then you end up just bathing it anyways, because
Mhm.
you can't get it in. So I think the pathology is important, and what tendon you're talking about, like you highlighted, there are a few of them do not do well.
Yeah.
So yeah, I think that part's important.
Thanks, that's great.
Let's
Yeah.
get segueing for the next one.
Oh, we got a question though, so.
Yeah, sorry. I think just to speak on the pathology side, trying to understand like what is the proposed mechanism for PRP in OA? Like, I think I understand it more from a tendinopathy perspective, but I just don't
Mhm.
understand how it's proposed to help from an OA perspective.
That's a
If
great
anyone else-
question.
Yeah, and maybe no one knows the
And I
answer.
thought about spending some time talking about that, and then I quickly thought that that would not be relevant. Because for me, is it better for the patient or not? I can have a great theory about why something works. And that goes for a lot of things in medicine too, right? Like this is supposed to work. And then we actually get into doing significant trials and of high quality and then find out, well, that doesn't work. Well, why? It's supposed to. Well, it just doesn't. And so I think that, yeah, I'm sure there's a mechanism. There's lots of in vitro analyses about what that can do, and rich versus poor, et cetera. But in the end, I just don't, looking at clinical data, at least as it stands right now, with all of those limitations and all of those differences and all of that heterogeneity, I don't know. I can sell a good story on it probably, but is that gonna, and maybe that's good. Maybe that's part of the effect. I don't know. But in the end, I think clinically relevant studies is what we need more of.
And we can re-ask that question to the Q&A panel.
Great.
All right.
Thanks, everyone.